Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very handy in your line of duty. I now welcome you all to part 224 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, OMN, a 33-year-old Somali man presented with a 6-month history of fever, weight loss, abdominal discomfort and swelling. OMN had also noticed recurrent epistaxis. OMN had left Somalia 1 year before his symptoms began. On examination, he was cachectic with bipedal edema. OMN's spleen was palpable 8 cm below the left costal margin. There were lymph nodes palpable in both inguinal chains. Investigations were done and results are as follows. Hemoglobin was 85 grams per liter. The normal range is 130 to 180 grams per liter. Platelets were 68 times 10 power 9 per liter. The normal range is 150 to 400 times 10 power 9 per liter. White cell count was 1.8 times 10 power 9 per liter. The normal range is 4.0 to 11.0 times 10 power 9 per liter. Albumin was 24 grams per liter. The normal range is 37 to 49 grams per liter. HIV-AGAB was negative. Bone marrow aspirate results are shown in the photograph in the next slide. Pause the video and carefully scrutinize the photo depicting OMN's bone marrow aspirate results before proceeding to the next slide. So my question to you is, what is the treatment of choice in OMN's clinical scenario? Is it A. liposomal amphotericin B or B miltefosine? Or C. paramomycin? Or D. pentamidine? Or E. sodium stibogluconate? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. liposomal amphotericin B. I will clarify why. Liposomal amphotericin B is rapidly effective against visceral leishmaniasis, and non-toxic. It is the drug of choice for ill patients with visceral leishmaniasis as it is the best tolerated and patients show a rapid response, that is, they become afebrile within 1 week, and there is normalization of clinical signs and laboratory abnormalities within 2 weeks. Please proceed to the next question. And the next question reads, ZMC, an 18-year-old girl presented with skin lesions on her right forearm and right cheek as shown in the photograph. They had developed gradually, from small papules which had enlarged and become nodular. ZMC had emigrated from Afghanistan 4 months previously. ZMC had no other known medical problems, and was not taking any regular medications. A skin biopsy was taken. Pause the video and carefully scrutinize the photo in this slide before progressing to the next slide. So my question to you is, what parasitic stage is most likely to be found in the biopsy? Is it A. amastigotes, or B. L3 larvae, or C. merozoites, or D. nurse cell, or is it E. tachyzoites? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. Amastigotes. I will explain why. In cutaneous leishmaniasis, amastigotes multiply in dermal macrophages near the site of inoculation. Please progress to the next question. And the next question reads, KHR, a 59-year-old man was admitted with new-onset urinary retention following 72 hours of dysuria, and 1 week of malaise. KHR had osteoarthritis of the right knee. He was not on any regular medication. KHR had returned from a 4-week holiday to Northern Australia 2 weeks before he developed symptoms. KHR's temperature was 38.3 degrees Celsius. His heart rate was 110 beats per minute. Blood cultures were taken. A digital rectal examination revealed a tender, boggy prostate. KHR was given a single dose of gentamicin dosed at 5 mg per kilogram and started on regular co-amoxiclav, dosed at 1.2 grams thrice daily IV. Investigations were done and the results were as follows. Transrectal ultrasound of prostate showed a large prostatic abscess, with a maximum diameter 4.5 cm. CT scan of the abdomen showed a small abscess in the upper pole of left kidney and pelvis. It was 2.4 cm in maximum diameter. His random glucose was 17.3 millimoles per liter. His glycosylated hemoglobin was 12.8%. His blood cultures grew gram-negative rods at 14 hours. Colonies on Ashdown agar are shown in the photographs. They were oxidase positive. There was bipolar staining on gram stain. Pause the video and carefully scrutinize the photo showing the colonies on Ashdown agar before progressing to the next slide. KHR was switched to meropenem. After 7 days he was still regularly having temperatures above 38 degrees Celsius, but was cardiovascularly stable. So my question to you is, what is the most appropriate management for KHR? Is it A. Add gentamicin, or B. Continue current treatment, or C. Switch to ceftazidime, or D. Switch to colistin, or is it E. Switch to trimethoprim sulfamethoxazole? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. Continue current treatment. I will explain why. Melioidosis is characterized by difficulty in eradicating the causative organisms. Fever clearance is often slow. It has a median fever clearance time of 9 days without evidence of clinical deterioration, which is not normally sufficient to indicate the need for a change in therapy. A patient who has clinical deterioration or persistently positive blood cultures should be viewed as failing treatment, at which stage the need for imaging, drainage of collections and change in antimicrobial therapy should be considered. Please proceed to the next question. And the next question reads, PLO, a 4-year-old boy in Kenya developed a painful lump in his left groin, preceded by systemic symptoms of fever, malaise, chills and headache for 24 hours. The lesion rapidly expanded in size, becoming increasingly painful and tender. On examination, PLO avoided movement of the area, and was reluctant for it to be examined. There was marked edema in the tissues surrounding the lesion, but there was no obvious overlying cellulitis, as shown in the photograph. PLO appeared systemically toxic, with a tachycardia and fever. Pause the video and carefully scrutinize the photo before progressing to the next slide. Investigations were done and the results were as follows. His peripheral white cell count was 36 × 10⁹ per liter. His platelet count was 87 × 10⁹ per liter. Microscopy of lesion aspirate showed small gram-negative cucobacilli with bipolar, safety PN staining. So my question to you is, what vector is most likely to have transmitted this infection? Is it A. Ixodes species, that is hard tick, or B. Leptotrombidium species, that is red mite, or C. Pediculus humanus, that is human louse, or D. Phlebotomus species, that is sand fly, or is it E. Xenosilla chiopus, that is rat flea? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. Xenosilla chiopus, that is rat flea. I will explain why. This is a case of bubonic plague, as typified by the acute onset of systemic symptoms with an exquisitely tender bubo that is a non-fluctuant lymph node with associated edema. The microbiologic and hematologic findings are characteristic of Yersinia pestis infection. Flea bites are the most common source of human Yersinia pestis infection. Antimicrobial prophylaxis may be offered to household contacts because of likely flea exposures. Please proceed to the next question. And the next question reads, JBO, a 5-year-old boy from rural Missouri presented with painful swollen occipital lymphadenopathy. JBO had a fever of 38.5 degrees Celsius, with no rash or meningism. On careful examination, a single papulo-ulcerative lesion with a central eschar was found on his scalp. There were no other abnormalities. A clinical diagnosis of ulceroglandular tularemia was made, and JBO was started on intravenous gentamicin. So my question to you is, what infection prevention procedures are the most appropriate? Is it A. Droplet precautions should be followed? Or B. He should be isolated in a negative pressure side room? Or C. Only immune healthcare workers should tend him? Or D. Post-exposure prophylaxis should be offered to close contacts? Or E. The diagnostic laboratory should be warned? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is E. The diagnostic laboratory should be warned. I will clarify why. As the infective dose is so low that is 10 to 50 bacteria, workers in the diagnostic laboratory who handle this organism may be at high risk for disease if exposed. Tularemia has been one of the most commonly reported laboratory-associated bacterial infections. Please proceed to the next question. And the next question reads, GOS, a 24-year-old man returned from a 4-week volunteering expedition in the slums of Mumbai. GOS had been fully vaccinated prior to travel, but had not taken any malaria prophylaxis. 1 week after GOS's return he developed sudden onset fever, rigors, myalgia and headache. On examination, GOS's body temperature was 38.1 degrees Celsius. His heart rate was 108 beats per minute. His blood pressure was 110 systolic, 55 diastolic. GOS was alert and oriented, and there was no neck stiffness or photophobia. There was no rash or lymphadenopathy. GOS had profound tenderness of the calf muscles and paraspinal muscles bilaterally, and bilateral conjunctival suffusion. Examination of GOS's cardiovascular, respiratory and abdominal systems was unremarkable. Investigations were done and the results were as follows. Neutrophils were 8.5 times 10 power 9 per liter. The normal range is 1.5 to 7.0 times 10 power 9 per liter. His platelet count was 124 times 10 power 9 per liter. The normal range is 150 to 400 times 10 power 9 per liter. His serum creatinine was 139 micromoles per liter. The normal range is 60 to 110 micromoles per liter. His serum ALT was 75 units per liter. The normal range is 5 to 35 units per liter. His serum creatine kinase was 455 units per liter. The normal range is 24 to 195 units per liter. His malaria film was negative thrice. So my question to you is, what is the most likely diagnosis? Is it A, dengue, or B, influenza A, that is H1N1? Or C, leptospirosis? Or D, non-falciparum malaria? Or is it E, scrub typhus? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C, leptospirosis. I will justify why. This is a classic case of leptospirosis, given the conjunctival suffusion, calf and paraspinal muscle tenderness and elevated creatine kinase. Contaminated floodwater in urban rodent-infested slums is the likely route of exposure to the leptospires. The clinical manifestations are highly variable, with many subclinical while a few are severe and potentially fatal. Conjunctival suffusion is useful in distinguishing leptospirosis from other common causes of fever. Please proceed to the next question. And the next question reads, MOW, a 34-year-old man in Kyrgyzstan presented with painless lesions on both arms. The lesions had begun as pruritic papules but had then enlarged, becoming vesicular, coalescing into bullae and developing significant local and spreading edema. MOW had systemic symptoms of chills and fever. The patient worked on a farm, and had handled cattle 6 days earlier. On examination there was extensive edema and hemorrhagic bullae in both arms as shown in the photograph. MOW had tender lymphadenopathy in both axillae. MOW's body temperature was 37.9 degrees Celsius. Swabs were taken of the vesicular fluid and a full-thickness punch biopsy was taken. Blood cultures were also sent. Microscopy using polychrome methylene blue stain showed blue-colored bacilli with light pink-colored capsules. Pause the video and carefully scrutinize the photo before proceeding to the question in the next slide. So my question to you is, what is the most appropriate antimicrobial? Is it A, benzylpenicillin, or B, ceftriaxone, or C, ciprofloxacin, or D, doxycycline? Or is it E, streptomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A, benzylpenicillin. I will justify why. Penicillin is the drug of choice in naturally occurring anthrax. This can either be oral or intramuscular in mild uncomplicated cutaneous anthrax, or intravenous in complicated or severe cutaneous anthrax. Penicillin is used in combination with other antimicrobials such as clindamycin and ciprofloxacin in inhalational anthrax, or with streptomycin in gastrointestinal infection. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 225.